Welcome, everybody, to the Cone of Shame Veterinary Podcast. I am your host, Dr. Andy Roark. Guys, I am here with Dr. Nathan Peterson. He's an emergency and critical care specialist. He is on the faculty at Cornell. He has a master's in bioethics from Harvard. I was talking to him about his master's of bioethics, and he said, I went and got this because of what my technicians were saying to me about their distress around some of the cases that we saw on the emergency service. And I thought it was fascinating. I thought it was terribly sad, but I really love the fact that Nathan sort of takes this interest in that and his sort of compassion for his own technicians, and he turned it into his own education. And now he's publishing research around, for both veterinarians and for technicians, around medical futility, or treatments that nobody thinks they're going to actually solve the problem, but we're doing them. Anyway, we get into what medical futility is. This is a really great episode. There's a lot of stuff here about how technicians and doctors look at challenging or possibly futile cases. How much do they look at them the same? How much do they look at them differently? What is the difference in agency between when you're a veterinarian and you're making the plan versus when you're a technician and you're being given the plan? What does that mean as far as the impact of these cases? And we talk about that. And then we start getting to some solutions. This is actually something that makes me really happy. I would tell you, this is one of the episodes that I come out of and I go, yeah, I'm gonna communicate a little differently with my support staff. And I mean that. So anyway, you'll hear what I mean in the episode, but this is a really good episode. This is an important episode. Guys, I hope you'll enjoy it. I hope you'll share it with some friends who might benefit from hearing it. Let's get into this.
This is your show. We're glad you're here. We want to help you in your veterinary career. Welcome to the Cone of Shame with Dr. Andy Roark.
Welcome to the podcast, Dr. Nathan Peterson. How are you, sir?
I'm good. How are you?
I'm doing great. I really appreciate you making time to be here. For those who don't know you, you are boarded in emergency critical care. You are an associate clinical professor at Cornell. You've got a master's in bioethics from Harvard, and you are the author of a research publication that came out in JAVMA recently. I was really quite interested in this when I saw it. It's called Veterinary Technicians Report in a Survey: How Futile Veterinary Treatments Contribute to Their Moral Distress and Impact Their Professional and Personal Lives. And so that's sort of what you started to talk about. I have an interest in mental health and wellness, especially sort of looking out for our technicians and things. I kind of wanted to unpack this with you because my first thought when I see it is, what it actually constitutes medical futility. And so can you just sort of start at that level and say, what do you mean when you say medical futility?
That's a great question. And, I wish I had a good answer for you. That's one of the things that has challenged us in doing this research, is really sort of trying to figure out how we define what medical futility is. Because if we're not all talking about the same thing, it becomes really hard to know when it's happening. The definition is slippery. The research that I did with my collaborators, we didn't establish a definition. We didn't provide a definition to our respondents, but we asked them to choose among a variety of definitions which they most closely identified with. I think traditionally we might consider futility to be providing a treatment that has no scientific way of achieving the goal that's being sought. So an example would be perhaps administering antibiotics for a viral infection. No matter how much we want that to work, it's futile. Antibiotics are not going to treat a viral infection. That's kind of one approach to looking at futility. But one of the things that we explored in this study and a previous paper that we did as a group also proposed a definition, or made it available to our respondents, to say perhaps futility is not defined so much as I can't achieve this goal, but maybe it's that a treatment becomes futile when the result of that treatment is prolonged or interminable suffering. So, I think that as a profession, and we're not alone in this, defining futility in human medicine, they experience the same challenges. But, I think that there's this idea of a physiologic definition where there's just no actual way this is going to do what we want it to do, versus an experiential definition where it's, hey, the end result of this is just to prolong suffering, and that makes the treatment futile. So I don't know if that really answers the question, but it's certainly something that we have wrangled with.
I think it speaks to sort of the nebulous nature. And I think that's kind of what I was most I don't know if I wouldn't say worried about, but it's what I wrestled with when I sort of read through the paper as well, is what is medical futility? I think, as a doctor, I wonder what choices I have made that have been perceived as being futile by the other doctors or by the support staff. There are times when you say, you go into the room and you have the conversation with the pet owner, and there is sort of a feeling of obligation I think a lot of us have of this might not be the best therapy, but it's the therapy that we can do. Or there's also, I think, a feeling that a lot of us have sometimes where you feel like you have to do something. The pet owner they want you to do something. And so you sort of wrestle with that. And then I see this impact on the technicians. And so I guess that's kind of, sort of the first thing that I sort of thought about. When you say, antibiotic for a viral infection, I think it makes sense. It's definitely not what I had imagined. I think I was definitely much more in the camp of, are we doing sub-Q fluids? And I don't know, and sub-Q fluids and antibiotics for a dog in advanced renal failure. And you say, well, this is definitely not helping us. It's, sort of prolonging life, but possibly not even avoiding suffering. I think I have felt futility in cases like that. Are there other examples of cases that you heard said back to you where people sort of said, here's an example? Were there any, I guess, common scenarios that seem to arise that people pointed to as an example of medical futility?
Sure, yeah. We didn't ask our respondents necessarily to describe specific events or episodes, but we did look at some specific interventions and sort of asked our respondents to rank how often have you performed this treatment or this intervention in an animal and you believed it was futile. So maybe other examples would be something like administering a blood transfusion to a patient with metastatic neoplasia who's not really expected to survive much beyond a week or two with or without the transfusion. I was a bit surprised in both of the papers that we did because when I embarked on this journey, I was convinced that futility happened in the hospital. It was those types of treatments were an in-hospital thing. And the results from both of the studies, and this technician one supported the first one, which surveyed veterinarians, but we find it happening in an outpatient setting too. So it might be similar to what you're describing. Hey, we continue to administer subcutaneous fluids to this patient that really has a degraded quality of life. And this is happening in an outpatient setting. So the reason that we chose not to offer a strict definition was because your experience is probably similar to mine. And it's that a little bit futility is in the eye of the beholder. I might feel like an intervention is maybe appropriate or could be on the cusp of being appropriate or not. And somebody from outside or through a different lens looks at it and says, you know what, this is way out of bounds. What are you doing here?
Yeah.
So, a little bit of that experience of futility, at least in my experience, is experiential and based on somebody's sort of prior experiences with those types of things.
Do you have even a sort of a gut feeling about the amount of overlap that you would see between technicians and veterinarians as far as these sort of cases of futility go? I guess what I'm saying is, do you get a sense that veterinarians and technicians kind of look at a case around medical futility and sort of both have an agreement, or do you feel like they tend to be often very disparate? And again, I'm sort of asking you to just say, do you feel like they're usually in alignment, or is it quite common to have one person who says, I know why this is happening and it's not futile, and the other person says, this is terrible?
Yeah, that's a tough question. And I guess all I can respond with is my own personal experience, because we didn't ask that question. But I think there is general agreement. If we were to ask both groups separately, do you think this proposed treatment is futile? I think that there would be pretty broad agreement between groups.
Okay.
But I do get the sense that the two groups don't communicate effectively about that. So I think that while they, in principle, might both agree that a proposed treatment is futile, when asked what they think the other group might think, I'm not convinced that they're going to agree, if that makes sense.
I think it does, actually. I think that's really interesting. As sort of think about these cases in my own mind, I definitely have thoughts about the probability of a medically positive outcome versus negative. And I usually don't probably talk about that with the technicians. And I wonder, I wonder what the benefit to that would be, and sort of if there's a way to open that conversation up. Are there, I don't know if there were sort of strategies. I don't know if there's research support for strategies around sort of addressing these sorts of things. But given what you've seen when you look at the veterinarians and you look at the technicians, are there paths to navigating these types of cases or best practices? Because we talk about clearly the negative effects that these cases are having on the individuals in the healthcare team. So what do we do about it? Are there ways to either navigate around these cases or at least to work through them in a way that's going to be supportive for the team?
This is difficult also because we propose some strategies in the paper that might help mitigate some of the negative consequences experienced by technicians in particular. But, I think from a veterinarian's perspective, maybe I just start there. In teaching the vet students, I like to talk with them about this idea, and that in practice, they're going to receive requests to perform treatments that they don't agree with on a moral level. And, I think there are different frameworks that have been explored in human medicine and pediatrics that I think could be applied here. And one is this idea of, it's called an IPO framework, where on a continuum, every treatment is going to fall somewhere on this spectrum. And at one end of the spectrum is there's no circumstance that will make this treatment a good option. So it's an impermissible treatment. And then on the other end, there's obligatory treatments. So no matter what the client wants, I'm not going to budge on insisting on these treatments. And then there's this wide range in the middle of treatments that are potentially permissible. So I think for an individual veterinarian, sort of establishing what they think those boundaries are, what's impermissible, what's obligatory, and then looking at all the treatment options they have sort of in between those two ends is a way to begin to address those types of requests that veterinarians receive. How to mitigate the impact of being asked to provide futile treatments from a technician's perspective, it's a lot harder because our technicians oftentimes have a very constrained sense of agency. They're not they're not privy to the decision-making process. They're sort of told what to do, and they have their own set of morals and values. And our study quite glaringly demonstrated that technicians are oftentimes asked to act against their conscience in providing certain treatments. And not only are they asked to do that, but they subsequently do that. So I think that as far as ways to mitigate the impact on our technicians, is to really try to get them involved in the process, in communication with the clients. In my own personal experience and kind of what led me down this path was, I would go into my office, nice quiet space, I'd have a difficult conversation with a client, and I'd tell them all of the things that I thought were important. I'd go out and I'd write the order, and I'd explain a little bit of the background to the technicians, and then I'd leave. And then they were faced with carrying out these treatments for hours or days, and they didn't feel like they could raise a concern or an objection. So I think what I tried to do is move those conversations into the presence of the technicians so that they are privy to them, and even potentially inviting them into the conversations. Yeah. Because if we look at the three primary stakeholders, not including the patient, but if we're just considering the veterinarian, the client, and the technician as the stakeholders, we all have different expertise and can all contribute to the decision-making process in a different way. And I believe it helps to get the technicians involved. And that's not just an anecdotal experience. It's bolstered by some research that came out of Colorado State where they looked at involving technicians in conversations with clients, and they ended up having higher compliance from owners when technicians were involved in those conversations. So I think that that's probably the biggest, easiest, lowest hanging fruit to try to mitigate some of these consequences.
I really love that you say that. It makes a ton of sense when you're sort of laying this out about the technicians investing the time and the labor, and they're not involved in the conversation or how the decision was made. I don't know. I think that that's definitely instructive for me, sort of looking in and how do I want to communicate with my technicians and make them feel included. When you're thinking about the studies that you did, and so, you think about the veterinarians and you think about the technicians, and we're talking about the magnitude of the impact of sort of medical futility. It seems to me that I would expect a much greater impact of medical futility on the technicians because of that lack of agency or that perceived lack of agency. If you're the doctor, at least you get to make the call. And, the technicians are being handed these sort of marching orders. And so when I think about impacts, I would expect to see a larger impact on the party that had less agency or less say in the path that we were on. Did you find that between the two studies?
That's a great question. The survey instruments were slightly different. So we didn't explore the impact as deeply in veterinarians as we did in technicians. So the veterinarian study was sort of like, is this even happening? Or is this just a kind of a me experience, for better or worse? So really, we're just trying to decide or identify whether this is a small thing or a big thing in the profession. But we did look at some of the impact on the technicians. We dove a little deeper into that. And we asked about physical manifestations of distress associated with providing futile treatments, and we asked about psychological impacts. And, not surprisingly, we found quite significant impacts, both physically, technicians reporting feeling nauseous, losing sleep, having elevated blood pressures and heart rates. And then we found an even higher degree of psychological impacts, feelings of anger, depression, guilt. And we explored how our technicians responding to this stress. And, we found that close to half of the respondents reported self-medicating with either drugs or alcohol to sort of cope with the feelings associated with providing futile treatments. And almost 10% had considered or attempted self-harm, which to me was just a devastating number. I agree with you. I believe the impact is probably more significant on our technicians because they lack the decision-making agency that the veterinarians have. And that is certainly documented in human medicine with human nurses having this constrained sense of agency, being ordered to perform treatments that they have a moral disagreement with, and lacking a seat at the table in the decision-making process. So, yeah.
That all definitely makes sense. When you think about these studies and you think about sort of medical futility in the vets and the technicians, Nathan, what is the next important question to answer, do you think? When you think about the future and say, given what we know now, what is the question that you're most interested in next in exploring?
For me, I feel pretty comfortable now that we've documented that at least some moral distress associated with futile treatment requests is prevalent in veterinary medicine. So, I think that the next steps for me are, exploring ways that we can really mitigate that distress, whether it's through education, whether it's through small practice changes, whether there are bigger structural things that we need to address within the profession. But really, I think that's kind of the next big step. And I'm hoping that by beginning this process, we can spark a conversation about futile treatment requests. And if we can't come to a consensus on how we handle them, at least we can advance the conversation and acknowledge that it's happening. To address the question in a very short phrase, I guess I would say, next step is try to figure out what to do about it.
Dr. Nathan Peterson, thank you so much for being here and talking through everything with me. Thanks for what you're doing for our profession. I think this is important, and whatever we can do to reduce turnover and keep people enjoying vet medicine longer, I think is really important. Where can people find you online? Where can they keep up with your research now in the future?
Yeah, I can be found on LinkedIn and certainly at the Cornell Vet website. And then ResearchGate probably is going to have some access to some of my other work.
Excellent. Well, we'll put some links so that people can find you. Thanks again for being here. Guys, thanks for tuning in, everybody. Take care of yourselves, gangs. We'll talk to you later.
Thanks a lot.
And that's what I got. Guys, thanks for being here. Thanks to Dr. Peterson for making time and walking us through his research. I feel optimistic coming out of this. It's sad that we have, hard cases like this. It's sad about the impact that our support staff feels in these sorts of cases. I thought Nathan started comments around substance abuse, around self-harm, just break my heart. But it's probably good for us to be reminded the people around us, they struggle, and we need to look out for each other and we need to take care of each other. And I do think that there's things that we can do to support each other. And I don't think it has to be massive changes. I think including people in the thought process. I think listening to our support staff, I think sharing our thoughts with our support staff, acting like a team, and just making sure that people are on board with what we're doing as best as we can. I think that there's real value in that. And in the moment, I know it's faster just to be quiet and get the case done. But I think that these things are important. And I think the future of vet medicine hopefully is around taking care of each other, communicating a bit better, and making sure that just that we're looking out for the wellness of our whole team. So anyway, that's what I hope for. It's what I aspire to. All right, guys, that's enough of that. Take care of yourselves, everybody. I'll talk to you later on.